So it increases by about 24% over the same period. So over a 10-year period versus over a 9-month healthy period of pregnancy. And over a hypertensive pregnancy, how much does it increase by? Here we go. 95%. Okay. So it's a huge amount that heart changes by. And then in the postnatal period, you've got this rapid de-remodeling, and that's essentially when the mum's heart, the cardiovascular system, and everything has to quickly reverse and go back to how it was before pregnancy. But the reality following a hypertensive pregnancy is this is often not the case, and it is often not successful. So long-term risks of pre-eclampsia. Pre-eclampsia is associated with a 2-fold risk of ischemic heart disease and stroke, and a 4-fold risk of hypertension. So these are not small risks. Preterm preeclampsia, so women who have preeclampsia and require delivery before 37 weeks are 3 to 8 times more likely to die from cardiovascular disease than a woman who had an uncomplicated pregnancy. And we know that worldwide, cardiovascular disease is the leading killer. It accounts for 1/4 of female deaths in the UK. And we also know that it's better to be proactive rather than reactive. So preventing cardiovascular disease is much better than waiting for it to occur and then trying to treat it. But that means we need to know who we should be targeting. Now, we know that preeclampsia is associated with postnatal cardiovascular dysfunction and future cardiovascular disease, and we therefore, as a room of people here who work in maternity healthcare, have a duty to acknowledge this, to educate women and explain that to women, and also to optimize their cardiovascular health. So why is there this association? And this is up for debate. There are lots of people in the academic field who have very strong opinions one way or another. The reality is we don't really know. Preeclampsia, as I'm sure you probably heard earlier today, we define it by endpoints, but probably it's actually several different disease types encompassed under one sort of name. So it might be different in different women. But we know that the risk factors for cardiovascular disease and the risk factors for hypertension in pregnancy are shared. So age, obesity, pre-existing hypertension, renal disease. But actually, when you account for all of that, when you do some clever statistics, you account for all of that, and there is still this clear link between preeclampsia and cardiovascular disease, showing that there's some sort of direct link between the two. So is it that preeclampsia causes an insult? So we know that preeclampsia, it causes endothelial dysfunction, microvascular dysfunction. So is that injuring the cardiovascular system and leaving some sort of permanent scar, essentially? Or is it the other way around? Is it that women, they fail the stress test, basically? They fail the stress test at pregnancy, and that is why they've got preeclampsia. So we know that women who have worse cardiovascular function postnatally are then at increased risk of recurrence. So there's different data from different studies that sort of hint towards either. It might be a combination of both. But the bottom line is it is there and it is real. So 45% of pregnancies in the UK are unplanned, and that really limits what we can do pre-conception. Yes, we should keep trying to improve pre-conception care, but for many women, it's just not possible. We know that for many adults, pregnancy is their first engagement with the healthcare system. So therefore, this sort of pregnancy period and the postnatal period is an ideal opportunity for risk screening and primary prevention. And I've just said this actually on an on-slide, but yes, I'm going to say it again for repetition. We have a duty as maternity healthcare providers to acknowledge this, educate the women, and really sort of act on it. In pregnancy, we've got some limitations, haven't we? Certain drugs you can't use in pregnancy. You've got to factor baby as well as mum. It's a little bit trickier. Postpartum is by no means a straightforward period of a woman's life, but they are typically motivated for their future health and future pregnancies, and there are less limitations in terms of what drugs we can and can't give compared with the pregnancy period. And there's also good evidence to suggest that early blood pressure lowering in the postnatal period reduces blood pressure long-term, reduces hypertension risk long-term, and that blood pressure around about 6 weeks correlates with hypertension risk later on, and we'll talk a bit more about that now. So really, if we improve blood pressure in the early postnatal period, we have a potential to make significant positive changes to a woman's cardiovascular health. So this is just straight from the NICE guidelines, so people might be familiar with these numbers. Hypertensive disorders of pregnancy. If someone's had previous hypertensive disorders of pregnancy, the risk of recurrence is about 1 in 5. If someone has had preeclampsia, any kind of preeclampsia, what's their risk of getting it again in the next pregnancy? 1 in, here's some. Okay, 1 in 6. So late preterm, I'll pretend that that's what everyone says. Late preterm, so women delivered between 34 and 36 and 6. What sort of do you think is their risk of recurrence with that? 104. And then if they deliver before 34 weeks, you're noticing this sort of gradient effect. The more severe or the earlier onset, the higher the risk. So what do you think? Less than 34, 1 in 3. But yeah, and then if you get less than 28, you're thinking probably more. So it's really important to be familiar with some of these numbers, because I think sometimes we give blanket explanations to people, but actually it's very different for a woman who had a little bit of pre-eclampsia at 40 weeks and required 1 dose of Levitol and went home versus the woman who delivered a baby at 28 weeks with severe recurrent pre-eclampsia. The risk for that woman's cardiovascular health and future pregnancy is very different. So this is just going to touch on some unpublished research that we've done here in Manchester, looking at preterm preeclampsia, so the highest risk groups. Firstly, looking at the cardiovascular function, basically, in women who've had preterm preeclampsia and how it changes over time. And these are some plots. I always want to call them vulvar plots, but apparently they are. Anyway, so here they are. So this is looking at your blood pressure change over time. And as you can see, these women were followed up within 3 days postpartum, 6 weeks, 6 months, and 3 to 5 years. And in those first 6 weeks, you get this nice decline in blood pressure, so big shift in the blood pressure. And thereafter, it doesn't really change. So total vascular resistance and left ventricular ejection fraction, that's the systolic function, so the heart's ability to pump. So the total vascular resistance, it increases in the first few weeks and then largely stays the same, okay? Systolic function doesn't really change. Left ventricular mass index, so that is the muscle bulk, the thickness of the ventricular walls. And you get this, I told you that it increased by 95%, and then you get this rapid de-remodeling where it goes back to what it should do, hopefully, and then sort of stays the same. And that's the same with E to E prime as diastolic function, so stiffness. So thickness and stiffness at the heart, you get this improvement in the first few weeks, and then it doesn't really change. So the next question is, how can we use the postnatal period as a lens to the future? So unsurprisingly, I've just told you that blood pressure and everything changes in the first few weeks and then stays the same. So we've demonstrated that blood pressure and remodeling, so the thickness of the heart muscle at 6 weeks, relates to a woman's cardiovascular risk several years later. So this is using Q risk. Has anyone heard of Q risk? So it's a 10-year cardiovascular risk score. It's looking at their risk of having cardiovascular events in 10 years. So that risk score was calculated 3 to 5 years after pregnancy. So really, those early parameters can potentially predict events later on in life. So how many of these women have abnormalities? So this is my cohort of preterm preeclampsia. So seeing them at 3 to 5 years, have a guess how many of them have hypertension? 20%, 45%. How many of them have new hypertension? So let's ignore all the ones who had high blood pressure before 20 weeks. How many of them had new onset hypertension postnatally? Yeah, said that again. Systolic dysfunction, so that's pump function, 17%. Diastolic dysfunction, so this is stiffness of the heart. Any guesses of that? So half of them had stiff hearts. And fibrosis, which we measured via cardiac MR imaging, we've only done this, we've done it more now, but we will by the end of this month have 20 MR scans to look at. But already over a third of those women had evidence of scarring, that is permanent, irreversible scarring on their heart in a seemingly should be healthy 30 to 40-year-old. So this is a huge problem. So preterm preeclampsia is associated with a high prevalence of cardiovascular impairment, and this persists 3 to 5 years post-delivery. You get dynamic changes in the first 6 weeks, and then 6-week and 6-month parameters largely reflect a woman's longer-term cardiovascular health. And it really does highlight the importance of the postnatal period, not just to say, phew, baby's delivered, job done, but to identify women at risk and to target with strategies aiming to improve their blood pressure, improve their de-remodeling, ultimately aiming to improve their long-term health. So what does NICE say we should do? So blood pressure target postnatally. It says we should start antihypertensives if a woman's blood pressure is over 150 over 100, and we should think about reducing it if it's less than 130 over 80. But there's something really important to think about in regards to that, because blood pressure changes hugely in that first week postpartum, and there's this particular spike around sort of day 3 to day 6. So we really need to be thinking, if we're going to be tweaking doses up and down or stopping medication or starting, and thinking about where the woman is on her postnatal journey. So if you've got a woman on day 2 who's got a blood pressure of 130 over 80 and NICE suggests that we should think about reducing it, think about that woman who wants to go home, who's going to have her blood pressure measured by the community midwife in a day or two, who's then likely going to just bounce right back with hypertension. And we have a significant load of women coming back to triage. And the problem is when they come back to triage with hypertension postnatally, you don't know who they're going to see. You're going to get varying plans. They're going to get more worked up. They end up on the postnatal ward. And it's a really burdensome journey for the women and all the healthcare professionals involved. So trying to think ahead of what that blood pressure is likely to do and plan for that. Anti-hypertensive choices. So NICE basically recommends once daily dosing. And the reason for that is because, as we discussed, the postnatal period is by no means a straightforward period of a person's life. It's chaotic. Some of these women have babies on the neonatal units. Some of them have experienced baby loss. And we need to try and give them the plan that's actually achievable. So any idea on antihypertensives that we commonly use? So we've got, so the NICE recommends the first line as enalapril. The reason for that is because it's taken from the adult hypertension guidelines. So it's not particular pregnancy postnatal research that says that's better than other things. But there's a couple of studies from the 1980s which says that it appears to be safe with breastfeeding, and it does appear to be safe with breastfeeding. But it's largely because ACE inhibitors are first line in the adult population. But it's one thing to think about is that normally we start the enalapril dose quite low, maybe starting at 5 or 10, depending on where you are. Some people starting at 2.5, which is probably going to do absolutely nothing. And then you've got to gradually increase it. Then you've got to think about the renal monitoring and where that's going to be done. You know, you use these, that can be done in the community. So it's by no means a straightforward journey. That doesn't mean we should use it, but it's sort of factoring that in, thinking about somebody who's going to be on it long term. Absolutely, it's worth putting that effort in. If someone's only going to, if you're anticipating they're only going to be on it for a few days, trying to sort of put the whole picture together. Then you've got your calcium channel blockers, so things like nifedipine, which is usually a twice daily regime, or amlodipine, which is something we commonly use. And then your beta blockers, atenolol, we don't use that very often. Labetalol, we sometimes use it, they've been on it before, and we're trying to work off weaning that off. But obviously the difficulty with labetalol is it's multiple doses a day, which is not ideal in this context. Any idea what NICE says in terms of going home?
48 hours if they went home.
So in terms of follow-up, you're right, there's some sort of rules as to how often they get their blood pressure measured. In terms of when they're allowed to go home, sometimes you'll find that people are sitting in the ward waiting for a perfect green bill of health. Their bloods all have to be normal, their blood pressure all has to be in the normal range. And that's, we need to show that things are safe and improving and safe, but really we're trying to sort of facilitate a safe discharge for these women. But if its blood pressure is less than 150 over 100, their bloods are stable and improving, and they feel well in themselves. And then in terms of follow-up, and this is something again that people really struggle with, the guidance says that women who are on treatment should have a follow-up with their GP or their specialist in 2 weeks, and then again at 6 to 8 weeks. And I think a lot of us write that in the care plan, but what's really important is communicating that to the women, that actually that will fall on her to organise that 2-week appointment. Because when we see women further down the line, the vast majority have never had that appointment. So sort of making people aware to get in there early and try and get that appointment with their GP. So we've had a long conversation about pre-eclampsia and hypertension in pregnancy and how that relates to longer term cardiovascular health, how postnatal period is our opportunity to jump in, identify risk and treat it, reduce it, etc. What does NICE say we should do? This cardiovascular screening. Okay, well, you're silent, which is probably good because it doesn't say anything. So you're right. And what about prevention? Does it say anything about how we should prevent cardiovascular disease in these women? So it does. It says the sort of it says the generic things like advise stop smoking, live a healthy lifestyle, exercise, low salt, low fat, and maintain a healthy weight. And then in terms of blood pressure, so we've said that blood pressure in the early postnatal period appears to be key in terms of their longer term blood pressure and health. What does it say about long term blood pressure monitoring? So actually, yeah, it doesn't say anything. So some of the other countries' guidelines do say, and our MFT guidelines do say, but NICE doesn't recommend any long-term blood pressure monitoring. We would normally recommend to everyone who's had hypertension in pregnancy to try home blood pressure monitoring if they feel comfortable with that, check in on it every now and again. If they're not on treatment, I usually sort of, it's arbitrarily say, you know, check in it every month or so just to sort of see that it's okay. If women aren't happy to do that, then we can check with their GP at least every year. But really, I think we could be doing a lot more. And I think this is where we need to change things over time. So this is a study that one of our master's students did looking at clinicians' awareness. So she conducted a survey, an online survey with clinicians. So 240 clinicians completed the survey, trying to understand the healthcare professionals' understanding of the relationship between preeclampsia and cardiovascular disease. She got a number of midwives, obstetricians, GPs. She found it really hard to get cardiologists, but less of them were interested. And what they found is that actually there was a good awareness that preeclampsia is associated with chronic hypertension and stroke. People were less aware that it was related to heart failure and vascular disease. And really, very few people recognise that these risks can occur in that first decade after pregnancy. We deal with young, usually relatively healthy individuals, and I think we need to sort of remember that actually these cardiovascular events can really occur quite soon after pregnancy. Less than half of obstetricians routinely counsel about long-term cardiovascular health, and the vast majority of midwives, GPs and cardiologists never counsel. The majority weren't aware of the guidance in NICE, although we have reflected on the fact that there isn't much in there in terms of what we should be doing for their long-term health. And really importantly, which is why this is part of today, is that the majority wished for greater education on this topic. So we next thought, right, well, so we've seen what the healthcare professionals think. Essentially, lots of them don't know as much as they should, and they want to know more. What do the women think? What's their experience? And really, so this was a series of online surveys and interviews with women who've had hypertension in pregnancy. And in terms of their experience, in terms of their knowledge, a lot of them felt like, well, I'm healthy, so I don't understand why it happened to me. I didn't really believe that it could happen. They felt completely overwhelmed during the pregnancy with the amount of information that was being thrown at them and trying to deal with when to birth baby, etc. And also, they felt they needed a lot of self-advocacy. So they felt that because people weren't giving the information that they wanted, they were having to go away and sort of Google and find out for themselves. And their challenges and barriers to sort of good postnatal counselling and discussion about things was they felt that there was a huge problem with communication between healthcare professionals and from healthcare professionals to them. They were getting lots of mixed messages about what was okay blood pressure, what wasn't, what they needed to do, whether it was gone once the baby was born or whether this was a lifelong problem. Unfortunately, one of the women described having a lot of trust in healthcare professionals as the experts at the start of pregnancy and coming away having lost that trust just because of all of that mixed messages. They also felt like there was this big issue with continuity of care. They weren't able to see the same person again, and they felt like they were part of a conveyor belt, really. This wasn't Manchester Northwest specific, this was across the country. So, yeah. And what women want, they really wanted, so they want to be fully informed. They want to know what they can do to be healthier. And the timing of it varies between women, but most of them didn't want to know during the pregnancy when they're sort of trying to deal with everything that's going on. But they do want to know early postnatally and then also sort of at later dates to be able to kind of process at a time that's right for them. And they really want some more continuity, basically, get some information given from someone who is invested in their long-term health. So what should we do? I think we should be counselling these women, really explaining to them what we know in terms of their long-term health and what can be done about it. I think we need to be ensuring that follow-up is in place. So not just saying you need to just have an appointment at X dates and X dates, but sort of reiterating about what that means to the women, how they get that sorted. And we need to be targeting any risk factors for cardiovascular disease or cardiometabolic disease. And really importantly, we need to be proactively treating hypertension postnatally. It's the one thing that we know works. We know that improved early postnatal blood pressure appears to improve long-term blood pressure. And we know that across the globe, pregnancy aside, that hypertension is the leading modifiable risk factor for all-cause mortality. And we're all familiar with treating hypertension. So this is something that we could do, but we could be doing better. So in terms of the information giving, women want to know more, but they want to know it in a sort of different ways. So Pearl Vaziri is one of our postnatal midwives who did a comment with us, and she works together with women with lived experience to design these information giving tools. So building on the findings from our previous study, by our master's student looking at sort of the mixed method study, looking at women's experience of what they wanted. She ran these focus groups, she co-designed the tools, and then she offering personalised risk advice basically and healthy lifestyle tips. So trying to move away from you need to lose weight and you need to eat healthily, don't eat salt, and think about how can we do that in a helpful package really. So culturally inclusive recipe links. So looking at sort of, okay, for instance, if you're looking at telling them not to eat salt, well, what could they put in their cooking that isn't salt but might give it some flavour? And then linking in, not trying to reinvent the wheel, but the VHF, Diabetes UK and NHS Healthier Families recipes have really good links to that you can put in your either a food type, like say you like cooking with plantain, or you like a particular type of cuisine, you can put that in and it'll send you links to recipes that are sort of healthy. So I think that's really helpful. And again, exercise, when you tell someone who's got a 3-month-old baby and they've just got out of NICU and they've got twins as well, number 4, and they're just generally a little bit stressed in life, that they need to do some exercise. The idea of them going to the gym, running a marathon is probably not high on their list. But even if you tell them something like, okay, well, brisk walking, you're walking the pram, if you're pushing the pram, trying to get your baby to sleep or just to have some fresh air, you can count Monday to Friday as a working week and you do half an hour a day. So you're walking fast enough that you're breathing a little bit faster, you may be feeling a bit warmer, but you can still have a conversation. That in itself sort of fits within sort of nice recommendations of cardiovascularly healthy exercise. So trying to package it in a helpful way rather than feel like we're constantly the people giving bad news and telling people off. And then again, she tried to sort of, I think this is really helpful. So looking at the risk, we talked about a number of those different risks. Twofold, they're 2 times more likely to have ischemic heart disease, 4 times more likely to have hypertension. But then turning that into what does that really mean? So there's different things between relative risk and absolute risk, aren't there? So what's the absolute risk to that woman? So for instance, following pre-eclampsia, and we talked in our preterm pre-eclampsia group, it's almost 1 in 2 who have hypertension. But here, looking at sort of, right, so you may be 4 times more likely to have high blood pressure, but for you, this means it's about 1 in 10 chance of you developing high blood pressure, if that makes sense. Does anyone have any questions about what we've discussed so far? So just to touch on the evidence base for different postnatal interventions. So there's lifestyle advice, so exercise, low salt, low fat diet, etc. Monitoring blood pressure, as we talked about, and then pharmacological treatments. So a number of studies have looked at different postnatal lifestyle interventions. They've been relatively small, but looking at sort of educational modules, lifestyle coaches, online behavioural interventions, aerobic exercise training, or a postpartum pre-eclampsia clinic. And overall, they've shown potential to improve cardiovascular health. They've not been big or long enough to say this will definitely reduce women's risk of heart attack, etc. But they've shown things like it improved women's diet or knowledge, or reduced their physical inactivity, or improved components of their cardiometabolic health or endothelial function. So there's a potential for improvement with these things. But lifestyle interventions they sound easy because it's not giving a drug and it's cheap, but they're actually much harder, really, than just prescribing a medication. Home blood pressure monitoring. Has anybody heard of SNAP2 or SNAP or POP? So these are some studies led by Oxford, but also now SNAP2 is running across the UK and Jenny's co-leading it as well, so we're recruiting in Manchester. But these are studies looking at self-management of blood pressure after pregnancy. So women have a blood pressure monitoring, have an app, and they use the app and the support from physicians to help them manage their own blood pressure and dose titration. And what they showed is that women who had that versus women who had standard care had better blood pressure. But what was really interesting is actually they may only have needed blood pressure tablets for a few weeks, but they showed lasting improvement in their blood pressure compared to women who didn't have that. And there's also evidence that these women, back to that question earlier on, had improved D remodeling. So the home blood pressure monitoring improved their early blood pressure control and it appeared to improve how the heart D remodeled and reverted back to normal. We did a study a few years ago called Pickup, looking at enalapril. So again, answering that question about are there any drugs in particular that we could do to reverse the remodeling. We showed, we were very excited at the time, we're going to continue to try and build on this work. But essentially, ACE inhibitors, they are medications that are used for high blood pressure in the adult population. They have been shown to reduce remodeling in sort of hypertensive adults. And in our group, we showed that it improved remodeling, it improved diastolic functions of stiffness, and was acceptable to the women. But what we don't know is if you stop the drug, does that continue? Is it an ACE inhibitor specific effect, or is it just because we know their blood pressure better? And there's lots of sort of questions that need to be answered in this space. And as a result of that, there's loads more research being done in this area, really trying to understand the relationship between preeclampsia and cardiovascular disease and what we can do in that postnatal period to improve things. So the final thing was really about INSIGHT. So INSIGHT is inter-pregnancy study of cardiometabolic health, and it's a translational research clinic or a hybrid clinic that set up in Manchester last year. And this is for women. I'd like it to be for everyone with hypertension in pregnancy, but currently that's just not possible. So it's just for women who've had preterm preeclampsia, trying to focus in on the highest risk group. So these women typically undergo a phone call in the first few weeks, or several phone calls from the MAVIS team, from the midwives, looking at their blood pressure control and titrating medicine where appropriate. And then they come and see me and Daisy, our research midwife, at 3 to 6 months postpartum for a face-to-face visit. And then we see them again, the research visit again, 1 to 3 years later, to try and understand how the two things relate. So the idea is that we're kind of focusing on 2 things: quality improvement, how do we improve postnatal care now for these women, and research, how do we improve our understanding of the relationship between postnatal health and long-term health, and how do we understand how we can improve it to improve a woman's long-term health, if that makes sense. And it's a bit of a busy, hectic clinic. We invite the women in, we have a chat about their pregnancy, we look through their placental histology and the results and everything. We counsel them about risk and about our future pregnancy, risk of recurrence, etc. We do a whole load of blood pressure measurements, so just standard blood pressure, and then the balograph, which is a research tool that we use that looks at blood pressure close to the heart and vessel stiffness. We also I do a carotid scan to look at their, again, sort of vascular health, do an echo at the bedside as well. And then we look at adiposity, so we do all sorts of like skin fold measurements, etc. We look at glycemia, and we store some bloods for future research. So the idea is that we're trying to improve care that we give to these women now and improve that continuity postpartum, but also to try and understand better in these particularly high-risk women what we can do about it in that time period. Anyone got any questions?